Hi and welcome to a new episode of your weekly medical TV show on Alkarma TV, White Coat. Today we'll talk about painful topic, which is chronic pain. We will talk about the latest procedure that help to manage chronic pain as well. Throughout the world, 1 out of 5 suffer from moderate to severe chronic pain. In a country like United States of America, chronic pain is affecting more people than cardiovascular disease, cancer, and diabetes combined. One of the most common reasons for seeking medical attention, second only to respiratory issues, is chronic pain. Today we'll focus on chronic back pain, neck pain, joint pain, and sciatica, and we'll discuss the latest minimally invasive procedure that help to manage different kinds of chronic pain. It's my pleasure today to host two of the outstanding physicians in Southern California, Dr. Rostam Khoshsar and Dr. John Hesu, to educate us more about chronic pain management injections and minimal invasive procedure. For interaction with the program, send in all your questions and concerns to our official Facebook page, White Coat Alkarma TV, or if you want to interact with my guest directly today, you can call the numbers that will be shown on the screen at any time during the episode, and we'll be more than happy to answer all your questions. To keep up with us, follow our Facebook page, White Coat Alkarma TV, or follow us on Instagram on White Coat Alkarma. And to watch our latest episodes, please subscribe to our YouTube channel, الكرمة TV, and please activate the notification bell. أعزائي مشاهدي قنوات الكرمة في كل مكان في العالم، بحب أرحب بيكم بحلقة جديدة من برنامجكم الطبي الأسبوعي وايت كوت على شاشات قنوات الكرمة. النهاردة هنتكلم على موضوع مهم جدا. كتير من الناس الحقيقة بعتت طلبت إن احنا نتكلم عليه، فكرة الكرونيك بين أو الآلام المزمنة عند ناس كتير جدا. الحقيقة واحدة من الإحصائيات أو واحدة من الدراسات اللي اتعملت هنا أثبتت إنه 77% أو تقريبا 80% من الناس كان عندهم آلام في الظهر في فترة معينة من حياتهم، في اللي منها طبعا راح على طول، بيبقى بحاجة حصلت أكيوت وراحت على طول، وفي اللي منها بيكمل وبيبقى آلام مزمنة. الحقيقة الآلام المزمنة في منها أنواع كتير جدا، منها آلام الرقبة المزمنة، آلام الظهر المزمن، الأطراف، والحقيقة النهاردة هنتكلم على ده كله. زي ما أنا ببتدي دايما مع حضراتكم بشوية إحصائيات في البداية عشان نعرف حجم المشكلة قد إيه. 1 من كل 5 في دولة زي الولايات المتحدة الأمريكية بيعانوا من أمراض الآلام المزمنة في الظهر، ودي بتبقى تكلفتها كبيرة جدا هنا نتيجة حاجتين. نتيجة أولا العلاج والأدوية اللي بتكلف البيشنتس، ثانيا حاجة اسمها loss of productivity أو عدم القدرة على الإنتاج، لأنه بما أنه الفرد ما بيروحش الشغل ما بيبقاش فرد منتج، وبالتالي بتتحسب بالطريقتين دول، تكلفة العلاج وكمان نقص إنتاجية الفرد. فكل دولة في العالم بتحسب التكلفة بتاع الآلام المزمنة بده. الحقيقة اتكلمنا يمكن من 2-3 على فكرة الأدوية اللي هي الأوبيتس أو المورفينات أو كل الكلاس ده من الميديكيشن أو من الأدوية. اتكلمنا عليهم، اتكلمنا على أضرارهم، اتكلمنا إمتى ممكن يستخدموا بعد العمليات والفترة قد إيه، لأنه دايما وأبدا كل العيلة دي من المورفينات أو عائلة الأفيون بشكل عام اللي بتطلع منها كل علاجات البين كيلرز بيبقى ليها يعني فرصة كبيرة جدا انه الفرد لو قعد عليها الفترة بيدمنها، وخصوصا كلنا بنستخدم الانواع دي من الادوية بعد العمليات الجراحية والكلام ده كله. النهاردة بنتكلم على الجديد في حاجة اسمها البين مانجمنت ميديسن او طب علاج الآلام المزمنة. يمكن ما بقالوش كتير، 15-20 سنة في العالم كله، ولكن الآليات اللي حصلت في النوع ده من الطب او في المجال ده من الطب اتطورت بشكل كبير جدا. بقينا نشوف انواع حقن مختلفه خالص. النهارده هنناقش انواع كتيره من انواع الحقن اللي تحت اللي بنسميها الالترا ساوند جايدد او اللي بتبقى موجهه عن طريق جهاز الالترا ساوند. فالنهارده هنشوف انواع الام مختلفه، هنناقش الام الاطراف، الام الظهر، الام الرقبه، هنناقش كمان السciatica اللي هو عرق النسا، وهنشوف الانجكشنز الجديده اللي بتستخدم في المجال ده بدل ما الناس بتفضل زي ما بنقول تبلبع في حبوب على الفاضي. كمان ما ننساش انه اي نوع من انواع الحبوب او الادويه بيبقى ليها اثار جانبيه. ناقشنا برضو في حلقات قبل كده الاثار الجانبيه للكلام ده، غير فكره الادمان، ولكن البين كيلرز العاديه اللي مش اوبيتس ليها اثار على المعده، قراح المعده، ليها اثار على الكلى. وبالتالي ناس قالت بدل ما احنا بس بنحط بريسكريبشنز لادويه، خلونا نشوف كمان الانجكشنز الجديده او الحقن. ففي انواع كتيره من الحقن هنناقشها النهارده او على مدار حلقتين. عشان اكون دقيق، النهارده هنناقش كل انواع الحقن اللي بتستخدم في علاج الانواع المختلفه من الالام المزمنه. وفي حلقه قادمه ان شاء الله خلال اسبوعين 3 هنناقش الحاجات الجديده زي السباينال كورد ستيميوليتر او السبيسرز او الراديو فريكونسي ابليشن. الحاجات دي كلها هنناقشها في حلقه مختلفه. تكنيكس برضو يعني ما بقالهاش كتير، ولكن بتستخدم بشكل كبير جدا في علاج انواع مختلفه من الالام المزمنه. بيسعدني ويشرفني انه يكون معايا النهارده 2 من افضل الناس اللي بتتكلم في الموضوع ده. دكتور رستم خوشسار، وهو رئيس قسم البين مانجمنت في واحده من اكبر الجامعات هنا UCI، رئيس قسم البين مانجمنت برضه في واحده من اكبر المستشفيات هنا كمان VA لونج بيتش. فالحقيقه هو يعني عنده تايتلز كتيره جدا، يعني شيء يعني كبير جدا ان اقعد قدامه اناقشه في فكره البين مانجمنت اوبشنز الجديده. كمان هيكون معانا دكتور جون هيسو، شفتوه حضراتكم من اسبوعين 3 ناقشنا الاوبيتس. فاثنين دول هيبقوا ضيوفي النهارده. زي ما حضراتكم عارفين، اي اسئله او استفسارات تقدروا تبعتوا لنا على صفحتنا الرئيسيه للبرنامج والرسميه وايت كوت الكرمة TV اللي ظاهره قدام حضراتكم على الشاشه. تقدروا تبعتوا لنا كل الاسئله والاستفسارات. كمان رقم القناه او رقم البرنامج هيكون على الشاشه قدام حضراتكم بعد شويه. لو حضراتكم عايزين تتواصلوا مع ضيوفي بشكل دايركت، اي اسئله عن اي نوع من الالام المزمنه اللي بتعانوا حضراتكم منها، تقدروا تتصلوا بالارقام اللي موجوده على الشاشه وتناقشوا ضيوفي في اي استفسار او في اي سؤال. قبل ما ابتدي بس عايز أأكد على نقطة السوشيال ميديا تاني، لأنه السوشيال ميديا موضوع مهم جدا. محتاجين دعم حضراتكم بشكل كبير جدا، التواصل معانا عشان نعرف كمان احتياجات حضراتكم ايه. زي ما شفتوا من شوية صفحتنا على الفيسبوك وايت كوت الكرمة TV، كمان صفحتنا على الانستجرام وايت كوت الكرمة زي ما قدام حضراتكم، تقدروا تبعتوا لنا. كمان مهم جدا ان احنا نشوف الفيدباك بتاع حضراتكم على واحدة من اهم السوشيال ميديا بلاتفورمز، هي اليوتيوب. القناه بتاع الكرمة على اليوتيوب تقدروا تشوفوا حضراتكم فيها احدث الحلقات من كل البرامج اللي بتنتجها قناه الكرمة. وطبعا من وايت كوت تقدروا حضراتكم تعملوا سبسكريبشن زي ما احنا شايفين. بعد ما نعمل السبسكريبشن في زر التنبيهات يا ريت نفعله عشان توصل حضراتكم احدث الحلقات واحده بواحده، لانه ده كمان بنعرف الفيدباك بتاع حضراتكم، تقييمكم ايه الحاجات اللي ممكن تتحسن، ايه الحاجات اللي عجبتكم، ايه الحاجات اللي ما عجبتكوش. كمان ده بيبقى نوع من السبورت على السوشيال ميديا بشكل كبير، احنا محتاجينه هنا في قناة الكرمة بشكل كبير جدا الفترات الجاية. ان شاء الله ربنا يدينا حلقة حلوة النهاردة. زي ما انا قلت هنناقش الآلام المزمنة، هنناقش طرق العلاج الجديدة عن طريق الحقن او التكنيكس الجديدة على مدار الحلقة دي، وحلقة قادمة الشهر الجاي إن شاء الله. فيلا بينا نبتدي فقرات برنامجنا النهاردة من وايت كوت.
Are you tired of being overweight? Do you suffer from diabetes? Do you suffer from hypertension? Do you suffer from obstructive sleep apnea? Do you suffer from hypercholesterolemia? Have you suffered from heart attacks in the past? Strokes in the past? Are you tired of being ostracized in public? Well, I have a solution for you. Robotic bariatric surgery. This can completely change your life. I'm Dr. Bobby Bascarow. I'm a robotic bariatric surgeon. I do robotic weight loss surgery, which can completely change your life. I offer 3 different types of surgeries that can completely change your life. The sleeve gastrectomy, the lap band, and the Roux-en-Y gastric bypass. One thing that's very unique about our program in that we have a dietitian, and you will get counseled on what to eat, what not to eat, and how to optimize the utilization of your tool for good weight loss.
Hi, my name is Dr. John Su. I'm an anesthesiologist. I've been in practice for 28 years. I went to Loyola Stritch School of Medicine in Chicago, then went for anesthesia training at Loma Linda University Medical Center in Loma Linda, California. At this time, my research involves treating patients in chronic pain. What I'm trying to do is allow patients to be treated for pain without having the danger of addiction, diversion, and abuse. And the way I'm doing that is by using a secure storage, safe dispensing unit. Please stay tuned for me on White Coat.
I'm Dr. Rostam Khoshsar. I'm an anesthesiologist with subspecialty fellowship training in pain management. I'm board certified in anesthesiology and pain management both. I finished my medical degree at Tehran University and I moved to US. I did my surgical residency at State University of New York in Buffalo, followed by anesthesiology residency at Drew UCLA Medical Center and fellowship training in pain management at UC Irvine, where I stayed as a faculty after finishing my fellowship training, and I'm currently a faculty of UCI. I'm also a director of anesthesia pain clinic at the Veteran Hospital in VA, which is a hospital that treats the US veterans. I'm also medical director of biohealth pain management. As you see, I'm very busy with treating patients in pain at UCI, at the VA hospital, and also in my private practice, biohealth pain management. I do a lot of research in the field of pain management. One of the most recent research that we did at the Veteran Hospital was regarding patients with PTSD or post-traumatic stress disorder, which I treat them by doing a stellate ganglion block, which is a nerve block in the neck. And that was filmed and aired by CBS 60 Minutes show just recently. Besides practicing medicine, I try to spend as much time as I can with my family and my kids. My hobbies are camping, hiking. I try to exercise and work out and stay physically fit. I do bike riding usually on Sundays and try to have a balanced life between practicing medicine and my family. I truly appreciate my family considering the fact that a physician's life is not as easy and I have to spend time with the patients, with the practice, hospital, and also spend time with my family as well, as much as I can, and thankfully they understand that. Stay tuned for me at White Coat program at Alkarma TV.
أخبار حوادث هنا وهناك، قتل ودمار في كل مكان، حقد، كراهية بتزيد مع الأيام، حاسس بخوف وقلق وحيرة وعدم أمان. خليك فاكر إنها نهاية الأيام، وده وقتنا نزرع ونحصد في حقل الكرام. عليك دور، صدق وشارك.
Are you tired of being overweight? Do you suffer from diabetes? Do you suffer from hypertension? Do you suffer from obstructive sleep apnea? Do you suffer from hypercholesterolemia? Have you suffered from heart attacks in the past? Strokes in the past? Are you tired of being ostracized in public? Well, I have a solution for you. Robotic bariatric surgery. This can completely change your life. I'm Dr. Bobby Baskerov. I'm a robotic bariatric surgeon. I do robotic weight loss surgery, which can completely change your life. I offer 3 different types of surgeries that can completely change your life. The sleeve gastrectomy, the lap band, and the Roux-en-Y gastric bypass. One thing that's very unique about our program is that we have a dietitian, and you will get counseled on what to eat, what not to eat, and how to optimize the utilization of your tool for good weight loss.
God created the heavens and the earth. He created the sky and the mountains. He created the unmeasurable stars of the universe. He created animals, all different types. He created you. Now it's your time to create opportunities for people to know Him. Alkarma TV, millions for Christ.
اهلا بحضراتكم مره تانية في فقرتنا الرئيسيه اللي بنتكلم فيها النهارده على الالام المزمنه بشكل عام، سواء الالام المزمنه في الرقبه، في الظهر، في الاطراف، في الايدين، الرجلين، بعرق النساء المشهور جدا باسم السciatica. كل ده هنتكلم عليه النهارده، وطرق العلاج الغير تقليديه اللي هي بعيد عن فكره انه خد حبايه وان شاء الله هتبقى كويس والكلام ده كله. النهارده هنتكلم على طرق علاج الحاجات دي الغير تقليديه بشكل كبير. It's my pleasure and honor to host 2 of the outstanding physicians in Southern California. We had Dr. John Hisu before. Welcome, Dr. Hisu, to White Coat. Dr. Hisu is an anesthesiologist at PIH Hospital, CEO and founder for iPill and QV Pharma, right?
Hi.
Hi, Dr. Hisu, and welcome to White Coat.
Thank you.
Dr. Rostam Khoshsar, clinical professor at UCI Irvine, director of anesthesia pain clinic at Veteran Hospital in Long Beach, and director for biohealth pain management. Welcome, Dr. Khoshsar, for the first time in White Coat. It's
Hi,
a pleasure.
I feel so honored to be here.
Same here, and we'll talk about pain management today. One of the most common problems that people seek in medical attention for. So in the beginning, I just want to know more about biohealth pain management, your website, how people can contact you for their chronic pain issues.
So I'm, as you mentioned, I'm a clinical professor at UC Irvine. So I do academic work. I'm also director of the anesthesia pain clinic at the VA hospital in Long Beach, and also involved in private practice called Biohealth Pain Management, or I'm the medical director of it. We treat a variety of the pain in biohealth pain management.
Okay.
So
we'll talk about like pain management specialty, but how people can contact you. Like we can put their website.
You can contact me through the office telephone number, or through the website, or through email that is up there, and they can reach us. Usually people have questions, they can email me and I return the emails, or they can contact, make an appointment, and come and see us in the office.
Okay, perfect. So in the beginning, what's pain management specialty? Like what kind of disease do you treat at biohealth pain management?
Good question. So pain management specialty is relatively a new specialty, especially in the U.S. It's usually people who go through pain management, they suffer pain,
Right.
any kind of pain.
Right.
But for a physician to be a pain management specialist, they usually anesthesiologists or physical medicine rehab. They do additional training, subspecialty training, and they become a pain management specialist.
Okay.
Pain is a major problem
Right.
in any economy. It's the #1 reason for admission to the hospital. It's because of the pain.
Right.
#1 reason for missing work is pain.
I'm in pain, so I wouldn't go to work.
Pain puts a lot of impact and pressure on economy, on people's lives, deconditioning, and not only the person who suffer pain is the one involved, but the whole family is involved.
Right.
So anybody surrounding the patient is involved with pain as well.
Okay. Dr. Hisu, different kind of approach for pain management through medications, I-pill dispenser. So if you want to talk a little bit about I-pill dispenser before we start our episode today about chronic pain management options.
Sure. The problem with the opioid crisis now is that there's a lot of pills out there.
Right.
There's 53 million surgeries, 548 million dental procedures.
Right.
And there's just a lot of pills. In fact, a lot of pills are unused. 3.3 billion pills will go unused and enter the community. 9 million pills are stolen from pharmacies and manufacturers, and they enter the community. So what I've done is built a tamper-resistant, secure storage, safe disposal dispenser that holds the pills in the dispenser. If it's tampered with, the pills are destroyed immediately, and at 90 days, the pills are destroyed, so you don't have excess pills anymore.
Okay. الحقيقة في سؤالي لدكتور كوشار عن ايه هو اللي بيتعمل في فكرة البين مانجمنت، قال انه البين مانجمنت هي تخصص يعني بقاله فترة مش كبيرة في الطب 15-20 سنة مثلا، وهو بيدور على الشكل الغير تقليدي اللي هو بعيد عن فكرة الأدوية والحبوب والكلام ده عشان يعالج فكرة الآلام المزمنة عند الناس. لكل المقيمين في جنوب كاليفورنيا الويب سايت بتاع بايو هيلث مانجمنت كان معانا دلوقتي، يا ريت نحطه على الويب سايت. دكتور كوشار واحد من الناس الكبيرة جدا في المجال ده هنا، وتقدروا حضراتكم تروحوا الويب سايت بتاع بايو هيلث بين مانجمنت، تبعتوا لهم في أي أسئلة أو أي استفسارات، خصوصا جمهور ومشاهدي برنامج وايت كوت هيبقى لهم كمان تخفيضات لو حضرتك ذكرت ان انت يعني تواصلت معاهم من خلال البرنامج. ففكرة البين مانجمنت سبيشالتي هي تخصص جديد بيساعد الناس بطرق مختلفة. سؤالي لدكتور هيسو كان عن فكرة الحبوب كشكل تقليدي، والنهاردة الحقيقة اخترنا ان احنا نجيب الشكل التقليدي في العلاج اللي هو عن طريق الحبوب، وهو كمان الرئيس شركة اسمها I-pill، ده ديسبنسر للحبوب عشان الناس ما تاخدش اكتر من اللازم او يبقى عندها مشاكل في ادمان الحبوب دي. الديسبنسر ده بشكل كبير جدا يعني بيديك حبايه حبايه، اذا ما استخدمتش الحبوب دي بتدمر اوتوماتيك خلال 90 يوم عشان يعني الناس ما ترجع لهاش تاني. دي فكره الاي-بيل ديسبنسر ببساطه كبيره جدا. Dr. Khoshsar, usually statistics showing us how big is the problem. So how big is the problem of chronic pain management or chronic pain in general?
So chronic pain, as I mentioned, is a major issue. Everybody knows. And it puts a lot of cost on treatment of the pain, a lot of cost on the hospital, a lot of cost on the economy, has a lot of burden. Out of the chronic pain, the most common one is back pain, which I believe, I mean, a lot of you who are watching this TV now probably have experienced low back pain sometime in the past or experiencing now. And the purpose of this session, I believe, is to educate you about the condition,
right,
about the symptoms, and about the treatment options that are available out there.
Okay.
So hopefully at the end of the session you would know if you go to your doctor, what questions to ask and what treatment options to ask for. Because in the field of pain management, what we do, we try to treat the pain not just with pain medication, however, with minimally invasive procedures, such as injections, such as nerve blocks, different many options, and every year and every month and every day there are new options coming in the market that we can utilize to treat the pain. But how significant is the pain? Pain is way more common than, the incidence of pain is more common than diabetes, than coronary heart disease, than cancer.
Combined. Chronic pain is more
all together.
Right.
So the incidence of pain is a lot more than those.
Okay.
As I mentioned, is the number one admitting diagnosis to the hospital is because of the pain. Number one reason that the patient, they go to the emergency room is because of the pain. And pain also, treatment of the pain has a lot of cost.
Okay.
Besides medication, I mean, injections, treatment, admission to the hospital, and the home care, and so there are a lot of cost in the economy.
Right.
Pain itself, the low back pain itself, annually costs about $90 billion.
Right.
Cost
Healthcare.
of treatment, the pressure on the economy because people have to miss work, it puts the pressure and cost on the economy. So altogether is about $90 billion.
Wow. That's just for medication. Another statistics are saying $26 billion for lost productivity. So it's over $120 billion every year just for chronic pain.
Absolutely.
Right. سؤالي لدكتور كوشار، الحقيقة دايما زي ما أنا قلت لحضراتكم بنهتم إنه دايما تكون معانا إحصائيات عشان نوري حضراتكم حجم المشكلة قد إيه. لو شفتوا حضراتكم سلايد مثلا زي رقم 5 هنوري حضراتكم إنه فكرة الكرونيك بين أو الآلام المزمنة على بعضها كده قد مرض زي مرض السكر، أمراض القلب والكانسر على بعض. الأمراض المزمنة أكتر منهم كلهم وبتعديهم كلهم في نسبة الدخول المستشفى زي ما قدام حضراتكم اللي على الشمال خالص. لو حطينا البوينتر هي دي فكرة الأمراض المزمنة أو الألم بشكل عام، أكبر واحدة على الشمال. الثلاثة التانيين هو السكر وأمراض القلب والكانسر مع بعض. الناس اللي بتعاني من الثلاثة مع بعض مش قد فكرة الأمراض المزمنة، لأنه ده مهم جدا. زي ما قال دكتور كوشار كمان بالنسبة للأرقام، تقريبا 90 مليار دولار تكلفة علاج الآلام المزمنة في دولة زي الولايات المتحدة، تقريبا 26 مليار دولار نتيجة عدم القدرة على الإنتاج، فده بيبقى مكلف للدولة بشكل كبير. Dr. Khoshsar, the most repetitive word we repeated so far is pain, right? In this session. So when can we say this pain became chronic? And what kind of chronic pain do we have in our body, like simply?
So when somebody starts having the pain, it's usually an acute pain. I mean, I'm talking about back pain specifically because that's the most common pain that we experience. Well, that pain is usually treated, hopefully is treated within a short period of time. But if the pain goes on for more than 6 months, it falls in the category of chronic pain.
Okay.
And that's when the treatment becomes more difficult. The type of pain that we have, there are different kind of pain. We have somatic pain and neuropathic pain. Okay. Somatic pain is a pain that usually starts in the muscle, bone, soft tissue, tendons, ligaments. Let's say someone who gets an arm fracture.
Okay.
Or a leg fracture. That's usually a somatic pain. As opposed to neuropathic pain, which is a pain that is caused by a nerve injury per se, such as a disc putting pressure on the nerve root cause nerve pain, and that's called neuropathic pain, such as someone who gets shingles.
Okay.
Shingles is an example of neuropathic pain because the problem starts in the nerve, and usually the neuropathic pain are the worst pain to treat and they're worst pain to experience.
And a lot of, like, some of our viewers are diabetics and they don't know what neuropathic means, right?
Brought up a good point. Diabetic neuropathy, people who are diabetic and they have burning and tingling and pain in their feet or their arms, it's a neuropathic pain.
Right.
And that's very hard to treat.
Okay. So it's coming from, because that's a very important point for people to understand. Sometimes we misperceive the pain. It's coming from a ligament or anything, and we think it's the joint or it's the bone. So it's important to understand different kind of pain. الحقيقة سؤالي دكتور كوشار كان عن امتى نقدر نقول انه الألم اللي عند اي حد بقى ألم مزمن او تحول لفكرة الألم المزمن، وايه انواع الآلام المزمنة اللي بنقدر نحس بيها. قال انه الألم لما بيقعد اكتر من 6 شهور ده كده بنقول انه الألم ده اتحول لألم مزمن. وزي ما هو قال انه احيانا بيبقى الألم ده جاي من مصدرين مهمين جدا، نوع منه بنسميه يعني حسي او نوع منه عصبي. الحسي ده اللي هو جاي من يعني الحاجات اللي حصلت بجنب المفصل، زي مثلا التواء في الأربطة، مشاكل في العضلات اللي حوالين المفصل، حاجة في العظم نفسه. كل ده بنسميه نوع من الآلام الحسية. في كمان نوع الآلام العصبية نتيجة توصيل الأعصاب. في كمان زي مثلا الأعصاب الطرفية بشكل عام. كتير جدا من مرضى السكر بيعانوا من مرض التهاب الأعصاب الطرفية. كل دي أنواع مختلفة للآلام المزمنة نقدر نحس بيها. وزي ما أنا قلت بنسمي الألم مزمن لو استمر أكتر من 6 شهور، وبنتعامل مع البيشنت ده على إنه مريض آلام مزمنة لو الألم قعد في نفس المكان أكتر من 6 شهور. Dr. Hisu, what's our options here when we talk about chronic pain? What's our options for treating chronic pain?
I think you have to understand what chronic pain is. Chronic pain is something that's learned. When you have two people who have the same stimulus, one person may not feel pain while the other person feels the pain is tremendous.
Okay.
So you have to think about the different reasons for pain. There's many different reasons. You have to have different options for the pain.
Right.
Medications,
Okay.
Physical therapy, you have drugs, you have different types of drugs, drugs to treat pain, drugs to treat the depression associated with pain or comorbidities around pain.
Okay.
There's a lot of options. And then Dr. Khoshsar mentioned interventional pain blocks and interventional devices. So there's a lot of options to treat pain.
Okay. And one of those medications is opiates. But before we get to opiates, I want an advice from you to our viewers today. Because a lot of those like painkillers are over the counter and they keep like popping pills all day long. So what are the side effects for those over the counter stuff?
The most commonly prescribed painkiller in the world right now is Tylenol.
Tylenol.
So you can't really pop too many doses of Tylenol because your liver can be greatly affected.
Okay.
And then there's a general consensus that if you take too much Tylenol, you don't feel like other people are going to have pain, so you don't have the empathy that most people do.
Right.
The next generation of pain medicines are called NSAIDs, or non-steroidal anti-inflammatory drugs.
Okay.
Those drugs they can affect the kidneys. So you can affect your kidneys and go into kidney failure.
Okay.
There's side effects to every drug out there.
So one of your advices today, just don't keep popping all those pills over the counter.
No,
It has to-
really, as a patient, you need to be followed by a physician.
Okay.
You should not be treating yourself. You should have a physician following you, and you should have a physician advising you and making recommendations for pain medicines.
اوكي. الحقيقه برضو كان سؤالي الدكتور هيسو عن ايه هي الاوبشنز او الحلول المختلفه للبين. زي ما احنا قلنا الحبوب واشهرها على الاطلاق هو التايلانول، وده موجود اوفر ذا كاونتر. ومن ضمن الحاجات اللي عايزين نقولها النهارده، بلاش الناس تروح تجيب ده وتفضل تبلبع فيه طول النهار عشان الالم، لانه ده له اثار جانبيه كبيره جدا على الكبد، بيبقى اثار جانبيه سيئه جدا. انواع تانية من الحاجات دي زي الايبوبروفين والحاجات دي بيبقى ليها اثار جانبيه على الكلى بشكل كبير جدا. كمان في ناس بتجرب الفيزيكال ثيرابي او العلاج الطبيعي، احيانا بيشتغل احيانا ما بيشتغلش. كمان فكره الانجكشنز وهنناقشها النهارده مع دكتور كوشار بشكل كبير جدا، اللي هو الحقن. بس الحقيقه قبل ما نشوف الاوبشنز بتاع الحقن، عايز اسال سؤال تاني بيبدو تقليدي. فكره الناس اللي بتروح من الادويه العاديه اللي بتبقى موجوده على الشلف لفكره الاوبيتس او المورفينات او اللي هي العائلات الافيونيه بشكل عام زي ما بنسميها. So long-term use of opiates sometimes has pros and cons. Like, what's the pros and cons for opiates?
Well,
it's a very general question. Right?
Yeah, the art of medicine's changed. Technology's changed. The evidence has been showing us that there's quite a bit of problems with long-term opioids. Hormonal problems are the things that most people are now beginning to see. Hormonal problems, people have hypogonadism, which means that your hormones, your sex hormones are being diminished. And that means your sex drive is diminished. That's one of the problems that's really starting to come up again.
Right. They increase prolactin levels, so they decrease sex hormones.
Correct.
Long-term use.
Correct. And then the long-term use is that people are beginning to wonder if long-term opioids actually treat pain well. And some of the studies are suggesting they don't.
Okay.
ICER, the Institute of Clinical and Economic Research, has basically come out in 2017 and said that long-term opioids don't really have a clinical validity or a economic validity.
Okay. هي برضو سؤالي دكتور هيسو بشكل كبير كان عن استخدام الاوبيتس او زي ما قلنا الحاجات اللي طالعه من ثمره الافيون بشكل عام، المورفينات والحاجات دي كلها. زي ما هو قال اللونج تيرم او الاستخدام على المدى الطويل احيانا بتفقد الفعاليه بتاعتها لانه جسمنا بيتعود عليها، بيبقى في فرصه لادمانها. كمان لكل الناس اللي سامعيني من الشباب بيستخدموا الحاجات دي احيانا عشان بيقعدوا في تمارينهم الرياضيه فترات اطول والكلام ده كله. الحاجات دي بتقتل تقريبا الهرمونات الجنسيه تماما زي التستوستيرون والحاجات دي، وليها مشاكل ضاره كبيره جدا على المدى الطويل، فنتجنب الحاجات دي قدر الامكان. So let's get in business in chronic pain and injections. What could be the reasons for if I have a simple back pain or neck pain or leg pain? What could be the reasons for those?
Okay, before I start answering the question, just want to add a brief sentence to what Dr. Su was saying, which I completely agree with him. And actually, we have a term called opioid hyperalgesia. Right. It means opioid itself. There's a research done that the high doses of opioid in long term can actually cause pain and can aggravate the pain as opposed to treating the pain.
Right.
Now, let's get to the most common pain that people experience, which is low back pain.
Right.
I mean, 85% of the people during their life at one episode or more, they experience low back pain.
Right.
And here we're going to talk about low back pain, which costs $20 billion, just the low back pain, annually in healthcare cost.
Wow.
And it's the fifth most common reason for going to see a doctor is low back pain.
Okay.
Low back pain is the main reason for disability for people under the age of 45.
Wow.
There's a lot of pressure on the economy.
Right.
Now, but what are the reasons for the back pain? What are the pain generators in the back? We have spine or vertebrae. We have disc between the vertebrae. So any of those can cause pain. Like if you get a spinal fracture.
We can get the picture with us and you can explain to us.
Sure.
لو نقدر نحط صورة يا شباب معنا بتاع العمود الفقري.
If you can put a picture of the spine on.
Yeah. It will be on the screen right now, and you can explain to us like which part of is which. And
okay, so you're talking about a vertebrae. We have starts from the brain stem or the bottom of the brain. The spinal cord starts and comes all the way down to, and in an adult, it basically ends at about L1, L2 level.
Okay.
So we have 7 cervical vertebrae, we have 12 thoracic, and we have 5 lumbar vertebrae, and then we have the tailbone, which is sacrum, and the coccyx. I'm going to talk about just the lumbar spine vertebrae.
Okay.
And but the spinal cord ends at about L1, but we have 5 lumbar vertebrae, which starts from L1 and goes all the way down to L5. The vertebrae itself can cause pain. You can have a fracture in vertebrae, the same as we get fracture in any bone in the body.
Okay.
The disc itself can cause pain. And of course, we have degeneration in the disc, usually with the age. And the disc degeneration, disc is a cushion between the 2 vertebrae.
Okay, yeah, so I like the simple language.
Yeah, disc is a cushion between the 2 vertebrae. When the cushion thins, the 2 vertebrae, they get closer to each other.
There's friction.
And we have also joints on the back, which is called facet joint.
Okay.
So facet joint also can cause pain, especially if the cushion between the two vertebrae thins out.
Okay.
At times, the disc itself, which has a nucleus inside, that can bulge out inside the spinal canal.
Okay.
And that can put pressure on the nerves and can cause neuropathy or radiculopathy. That's what's called sciatica.
Okay.
So that's when we start having pain shooting down the leg.
I have a question here. What radiculopathy means? Because that's a little bit of a scientific
Okay,
term.
well, we went too medical here now.
Right.
So sciatica is a layman term for radiculopathy, basically,
Okay.
which means a pain that radiates down the leg from the back.
Okay.
That happens if the disc puts pressure on the nerve. Actually, I'm going to make a correction to it.
Okay.
That's what usually people think, that the disc puts pressure on the nerve. A lot of time the disc doesn't really put pressure on the nerve. What happens when we get a disc herniation or a disc rupture? A lot of chemicals are released in the epidural space around the nerves,
Okay.
such as if you get a burn. You see how it swells up, it becomes red, inflamed, painful, tender. Same or similar chemical reaction happens in the epidural space around the nerve root.
So it's an inflammatory process around
Exactly.
Okay.
Those chemicals are the one that they irritate the nerve.
Okay.
And a lot of times it's not the actual physical pressure of the disc on the nerve.
Okay.
But besides disc and bone and facet joint, we have muscles, we have ligaments, we have other organs close to the spine that can cause pain as well. As a matter of fact, the most common reason for the back pain itself, I'm talking just the back pain and not the sciatica, is usually myofascial pain, which is muscle, ligaments, tendons. They become spastic and they become painful, and the pain could be very severe, sharp, and very bad and debilitating.
Okay. You mentioned the tons of stuff here, a lot of stuff. The pain could be coming from the ligaments, muscles, the disc itself, the vertebrae friction together, right? Or the nucleus at the disc, or the nerve compression, all of those stuff. Before, let's say like I'm your patient now, and I have back pain. Would you walk me through to the algorithm of diagnosing me before you see me, like which one of those causing the pain? So what's the right way to diagnose like those patients?
So when we see a patient coming as being referred to the practice, the pain management practice, the patient usually has been seen by a primary doctor,
right,
or by an emergency room doctor. So patient with back pain, especially with acute back pain, they go to a doctor. They get some sort of diagnosis. They get a little some medications such as muscle relaxants or painkillers,
physical therapy, they have
physical
gone through all
therapy,
those
and
steps.
so and so, and then the pain is still there and persists, and now being referred to the pain management. What starts with a right treatment is a right diagnosis. So if we don't have a right diagnosis on the patient, we cannot come up with a right treatment plan.
Right.
So first, we have to do a right, correct, comprehensive physical exam and get a comprehensive history to find out how the pain started. Was it an accident? Did you bend to lift something and the pain started? Did you turn around? Did you fall down?
Like what happened before.
So the history is important. If it's a trauma, the way that the trauma happened is very important. Is a car accident. And then we do proper physical exam with the tools that we have, and then we come up with the right diagnosis. And then at that point, we can go with the treatment.
Perfect. Before I translate, we have a phone call from Virginia. Let's take some phone calls.
Sure.
Phone calls. اوكي معنا ماري من فيرجينيا. حضرتك على الهواء يا فندم، اتفضل.
ماري عبد الله من فيرجينيا.
اتفضلي يا فندم.
سني 80 سنة.
اوكي.
أنا بقالي 12 سنة باخد الترامادول.
اوكي.
عشان مشكلة ظهري، عندي صقرتين اللي تحت ضاغطين على النرف بتاع رجلي الرجل اليمين
أوكي.
والرجل الشمال.
اوكي.
يعني عايزة دلوقتي أعراض الترامادول، الدوخة والحاجات دي دلوقتي عندي، وتعباني الدوخة تعباني قوي.
اوكي.
زائد ان انا مش عارفه امشي دلوقتي.
حضرتك
من
عملتي
ألم رجليا.
حضرتك عملتي انجكشنز قبل كده؟
الترامادول ما عادش يعمل حاجه.
حضرتك عملتي انجكشن قبل كده؟ حقنتي قبل كده؟
اخذت حقن، اخذت بتاع 4 مرات، بس اخر مره.
انهي نوع من الحقن؟ حقن في ظهرك؟ يعني حقن ايه؟
ايوه في ظهري.
اوكي.
في المكان بتاع الفقرتين.
اوكي.
اتكلم ولا حضرتك؟
لا سؤال حضرتك ايه؟
سؤالي ان انا باخد ترامادول بقالي 12 سنه، والسايد افكت بتاعه بقى دلوقتي بقى ماسكني جامد، الدوخه والاعراض اللي هي تحت المشكله دي. فاعمل ايه؟
اوكي.
يعني
يا حضرتك بتسالي على الحقن، اذا الحقن يبقى اوبشن كويس لحضرتك تاني ولا ايه السؤال؟
انا نفسي اخد حقن تاني، بس الدكتور اللي بيديني حقنه قال لي المره دي المكان ده قوي وما بقتش عارف ادخل الحقنه.
اوكي.
يعني فكري في العمليه.
She's 80 years old.
انا العمليه في السن ده ما تناسبنيش يعني، وخايفه بصراحه.
حاضر يا فندم، هنجاوب سؤال حضرتك.
في ادويه ثانيه بخلاف الترامادول؟
انا هجاوب حضرتك كمان على الحقن، لانه يعني هم اكتر متخصصين في الجزء ده.
I was hearing tramadol a lot.
Yes.
Is that what it is?
Yes, she's 80 years old, and she has been on tramadol for 12 years. She has tried epidural injection 4 times. It helped a little bit. Then it stopped working. She's thinking about surgery versus more injections. She has a problem with lumbar 4, lumbar 5 S1. So what do you think with her age?
Well, welcome to the world of pain management. So that sounds like a classic patient who have been in chronic pain and discogenic pain in the spine, and now being on medication for treatment. They have tried different options, such as epidural injections, and now they're stuck. They're thinking of whether they have to get the back surgery done. Are there any other options available?
Right.
Just to reassure you, there are many other options available besides just the epidural injection.
One of the things that I want to mention to you before you evaluate her, that the intervertebral disc space has been narrowing every time she's doing injection, and her pain management physician told her the space is very narrow and he has a concern injecting her.
So, I mean, I assume, of course, I don't have the MRI in front of me to take a look, but I assume she's suffering from something that's called spinal stenosis. Or narrowing of the spinal canal.
Right.
Just a brief treatment options I want to summarize basically the treatment options for spinal stenosis. Spinal stenosis is a physical effect, which means the spinal canal has been narrowed. Epidural injection, they're usually steroids. They reduce the inflammation, but they cannot open up the spinal canal, which has been narrowed.
Okay.
That's why epidural injection usually they don't work well in the case of spinal stenosis. If it works, it's very short term.
Okay.
What are the options? Number 1, surgery. Of course, if you see a spine surgeon and say, you know what, we have to do laminectomy, which means take the bone out.
Right, and she has a concern about that with her age.
And give more space to the spinal cord or the spinal canal and the nerve roots. And usually when they do that, if it's more than one level, they usually fuse as well. So they have to fuse the vertebrae. When I say pain management is new field with new advancements, there's a new technology in the market that came in about 1.5 years ago, which is called VertiFlex Superior. That's specifically for a spinal stenosis.
VertiFlex Superior.
VertiFlex. So this is a little tiny device with a very small incision in the back, with a little tube. We go in between the 2 vertebrae. We put that between the 2 spinous processes, between 2 vertebrae. It lifts up the spinous process and the space between the two vertebrae and reduces the spinal stenosis.
Okay.
The outcome has been great, has been magnificent. It's an outpatient procedure, which means once it's done, the patient walks out of the bed and goes home.
Wow.
I just recently did it on a 92-year-old gentleman,
Wow.
which was on a wheelchair when I first saw him.
Okay.
After the procedure, when I saw him for the post-op, he was walking with a cane, upright, happy, laughing.
Wow.
So that's how
Amazing.
it's like night and day, the
Right.
result.
الحقيقه برضو انا هلخص بقى كل اللي اتقال قبل ما ناخد بريك. دكتور كوشار كان بيتكلم على اسباب الام الظهر بشكل كبير، قال انه ليها اسباب كتيره جدا ممكن تبقى جايه. يا ريت نجيب الصوره معانا بتاع العمود الفقري عشان اشرح اللي هو قاله او اترجم اللي هو قاله بشكل كبير. زي ما دكتور كوشار قال في الاول، دي صوره العمود الفقري معانا، اللي بالاحمر او الفقرات اللي بالاحمر بنسميها الفقرات العنقيه، اللي بالاصفر بنسميها الفقرات الصدريه، اللي بالازرق الفقرات القطنيه، او اللبني الازرق الغامق بنسميها الفقرات العصعصيه. والحقيقه معظم الام الظهر بيبقى جاي عن طريق اللي هم الخمس فقرات اللي هم اللبني الخفيف دي. يا ريت دايما نتابع ونحط بوينترز معانا عشان الناس تبقى عارفه احنا بنتكلم على ايه. فالفقرات اللي باللبني الخفيف دي نقدر يعني هي بتبقى مصدر الام الظهر. الفقرات اللي بالاحمر اللي فوق بتبقى مصدر الام الرقبه والايدين بشكل كبير جدا لو في مشاكل من العمود الفقري تحديدا. زي ما قال دكتور كوشار، هي الفقرات دي اللي بتبقى السبب. احيانا بتبقى الفقرات نفسها، احيانا بيبقى الغضروف اللي بين الفقرات دي بيتاكل، فبالتالي الفقرات دي بتخبط في بعضها وبتعمل الم. احيانا بتبقى الاربطه اللي حوالين الفقرات دي هي اللي عامله مشكله. احيانا العضلات اللي بتبقى موجوده اللي بيبقى فيها تقلص شديد جدا وهو اللي عامل مشكله، دي الام الظهر بشكل عام. احيانا الفقرات دي بتضغط على العصب اللي طالع ما بينهم، ودي بتبقى حالات كتير جدا. كان معانا تليفون من مدام ميري قالت انه الفقره الخامسه الرابعه والخامسه في الفقرات القطنيه كان فيها انه هي ضغط على النيرف بشكل كبير. زي ما قال دكتور كوشار انه وكمان هي اشتكت من فكره انه السبيس ما بينهم بيضيق بشكل كبير. زي ما قال دكتور كوشار في تكنيك جديد مدام ميري. اذا انا بقول اذا في 10 بيتكلموا على البين في امريكا كلها هيبقى دكتور كوشار واحد منهم. الحقيقه في تكنيك جديد اسمه فيرتيفليكس اللي هو اتكلم عليه، هيبقى مفيد جدا لحالات دي السباينال ستينوزيس اللي عند حضرتك. هيبقى مفيد جدا في الحاله دي. زي ما هو قال الاسبوع اللي فات عمل بروسيجر لحد عنده 92 سنه وروح البيت في نفس اليوم والالم قل بشكل كبير. هنتكلم على كل الاوبشنز دي ما بين النهارده والحلقه اللي جايه ان شاء الله، ولكن الفيرتيفليكس ده قال انه اوبشن ممكن يبقى كويس لحضرتك. هناخد بريك ونرجع مع حضراتكم نتكلم على كل الجديد في علاج الآلام المزمنة سواء للرقبة للظهر للأطراف. ناخد بريك ونرجع نشوف حضراتكم تاني.
Are you tired of being overweight? Do you suffer from diabetes? Do you suffer from hypertension? Do you suffer from obstructive sleep apnea? Do you suffer from hypercholesterolemia? Have you suffered from heart attacks in the past? Strokes in the past? Are you tired of being ostracized in public? Well, I have a solution for you. Robotic bariatric surgery. This can completely change your life. I'm Dr. Bobby Bascarow. I'm a robotic bariatric surgeon. I do robotic weight loss surgery, which can completely change your life. I offer 3 different types of surgeries that can completely change your life: the sleeve gastrectomy, the lap band, and the Roux-en-Y gastric bypass. One thing that's very unique about our program in that we have a dietitian and you will get counseled on what to eat, what not to eat, and how to optimize the utilization of your tool for good weight loss.
أخبار حوادث هنا وهناك، قتل ودمار في كل مكان، حقد، كراهية بتزيد مع الأيام، حاسس بخوف وقلق وحيرة وعدم أمان؟ خليك فاكر إنها نهاية الأيام، وده وقتنا نزرع ونحصد في حقل الكرام. عليك دور، صدق وشارك.
أهلا بحضراتكم مرة تانية في الجزء الأخير اللي بنتكلم فيه على الآلام المزمنة وطرق علاجها. الحقيقة واحدة برضو من الحاجات اللي الناس بعتتها لنا كتير إنه بيستخدموا أوبيتس لفترات طويلة، ودلوقتي بيفكروا يعملوا يعني عمليات في ظهرهم والحاجات دي، فبيسألوا سنس إن هم بيستخدموا الأوبيتس دي لفترات طويلة التخدير هيبقى أخباره إيه؟ Dr. Hisu, one of the most difficult patient to put them under anesthesia is long-term opiate users. So as an anesthesiologist, what do you think about long-term opiate users and anesthesia?
Well, that's the most difficult part of anesthesia, is trying to figure out how much opioid, how much pain a patient's going to be in after and before. And we get a good
because
forecast.
they build tolerance.
Yeah, they build tolerance, and
Right.
we don't know how much tolerance they have.
Right.
Frequently, we think that patients who have long-term opioids can tolerate a lot of opioid. You have people who have 300, 400 morphine milliequivalents of morphine.
Wow.
Whereas a person who hasn't taken much morphine, you give them 10 of morphine, they may stop breathing. But then you have people who take 300 to 400 milligrams of morphine.
Right. Opiate naive versus long-term opiate.
Correct. And those are the patients that are difficult to put to sleep because you don't know exactly how much to give them.
Okay. So is it those patients are hard for you to put them under anesthesia? Is it harder, I mean?
It is harder. But there's a new concept in anesthesia now is to pre-treat these patients with other drugs besides narcotics to decrease narcotic intake and to decrease their pain. So for instance, we talk about neuropathic pain. We give something pre-op to try to calm the nerves, so to speak. So you decrease the impulses getting up to the brain.
Okay.
And then we give something for the perception of pain preoperatively, so that they don't perceive the pain as being very significant or as significant.
Just decrease the perception level of the pain of those patients.
Correct.
Right.
When you're asleep, you can't feel pain.
Right.
It's only when you're awake you feel pain.
Right. الحقيقة يعني كذا سؤال جالنا على فكرة انه الناس بتستخدم الاوبيتس زي ما انا بقول فكرة كلمة اوبيتس زي المورفينات والحاجات دي كلها، ودلوقتي بسبب آلام الظهر ودلوقتي عايزين يدخلوا يعملوا عملية، فبيسألوا تأثير ده على التخدير ما قبل العملية. زي ما قال دكتور هيسو انه بيبقى صعب جدا فكرة تخديرهم لانه بنوا حاجة اسمها tolerance، فبالتالي بيحاولوا يدوهم جرعات اعلى. فنخلي بالنا من فكره استخدام المورفينات. حاجه كمان مهمه جدا انه بيدوهم ادويه جديده دلوقتي بتقلل التوصيل العصبي للبين وبتهدي الاعصاب شويه قبل العمليه، عشان ما يستخدموش كميات كبيره من الاوبيتس عشان ممكن تاثر على التنفس بتاعهم اثناء العمليه. دول ال3 4 اسئله اللي جم في الحته دي تحديدا. Dr. Khoshsar, now we're in your territory. Pain management, epidural injections, right? Would you like to show them the video first and you explain it, or you want to explain it first? It's up to you.
Actually, we can put the video on and then I
explain
can
it during the video.
During the video.
لو نقدر نحط فيديو واحد معانا شباب من غير صوت، ودكتور كوشار هيشرح بالظبط اللي بيحصل في الفيديو. So that's the procedure of the epidural injection.
So, I mean, before we go over the procedure of the epidural injection, let me give a brief oversight of what epidural injection is.
Okay.
A lot of people think of back injection as epidural injection.
Okay.
Epidural injection is only one of the many injections that we do in the spine.
Okay. So there is different kind of back injections.
Absolutely. There are different kind of injections, but in general, people think that any back injection is epidural injection. And the moment the word epidural comes up, they all get scared.
Okay.
And then they kind of mix it up with the labor epidural, or the epidural that a pregnant woman gets when they are going through labor,
okay,
which is completely different. However, epidural is a space around the spinal cord, around the spinal sac, basically.
Okay.
Epidural injection is entering the epidural space with a needle, injecting steroid in the epidural space, trying to reduce the inflammation and the pain, and subside the pain, basically.
Okay.
So when we want to do epidural injection, we numb the skin, we go with the needle in. Once we're in the right spot, we inject a little bit of contrast solution just to make sure that we are in the right spot. Of course, the procedure is done under fluoroscopy or continuous x-ray. So as we are going in, we are watching on the monitor where we are going and where we're injecting. Once you make sure we're in the right spot, then we inject usually steroid mixed with local anesthetic. And then, but how does epidural injection work?
Right. So if you want to explain this process with us here, like simply, in simple steps, like what happens, then what's the next step and all that stuff.
What happens
with the procedure itself on the video. لو نقدر نحط الفيديو معانا مع
So
Dr. Khoshsar.
patient comes in. So let's say we are scheduling a patient for epidural
we have
injection,
it here with us.
and we are performing epidural injection. Patient comes in. We usually give the patient sedation, IV sedation, so that the patient, they feel comfortable going through the procedure. They lay on their stomach. We use a fluoroscopy on top of them, which means that continuous monitoring and imaging. We get the image, and then we go find the right spot, inject numbing medicine, local anesthetic at the skin. We go with the epidural needle in. We use a technique called loss of resistance technique. Once you find out that we're in the epidural space and it's confirmed by fluoroscopy or by continuous imaging, we inject contrast. Once we inject contrast solution, then we are confirmed we're in the right spot, and we are confirmed also that the medicine is not going into the vasculature, is not in the blood vessels.
Okay.
Because there are blood vessels also in the epidural space. Once they're all done, then we inject the steroid mixing with local anesthetic, and then we pull the needles out. Okay. So that's as simple as it is. It usually takes about 5 minutes on an experienced hand to do an epidural injection. Of course, there are like some risk involved, but the risks are very, very, very minimal.
Okay. I have all the questions here since you started epidural injections. I'll take some questions from social media. How often can we do epidural injection? I'll ask you like multiple questions, and I need short answers.
Okay. Well, first of all, epidural injection is not the solution for everybody.
Okay.
So not any back pain can be treated with epidural injection. But we're going to go over that later. Epidural injection is usually done for discogenic pain.
Okay. So pain's
or
coming
for
from the
sciatica.
disc.
When when the pain is coming from the disc itself.
Okay.
When the disc is putting pressure on the nerve root or the inflammation is caused by the disc and is just kind of narrowing the neural foramen, narrowing the spinal canal, putting pressure on the nerve root, inflammation is in there, then we inject steroid or epidural. And that's actually how the epidural works.
Right.
I mean, injecting steroid in the epidural space reduces the inflammation around the nerve root. That's how it reduces the pain.
I have a question here too. From...
Let me answer that one quickly. How many times you do the epidural injection? I mean, usually we do about 3 to 4 epidural injections in a year, and that's max.
3 to 4?
3 to 4 in 1 year.
Okay.
And that's the maximum.
Could
Some
it be
people
repeated?
start doing like 1 every 2 weeks. They do a series of 3 injections. The recent study shows that 1 injection could be as effective as 3 injections.
Okay.
So there is no point of doing 3 back to back. But we can do up to 3 or 4 in a year. People have done more, nothing had happened, but usually the chances of complication goes higher if you do too many of them.
Okay. Could it be repeated? Like
it could be
3,
repeated,
4
absolutely.
every year maximum, but it could be repeated.
Absolutely.
Okay. I have one of the questions here. One of our viewers is asking, she has one of her cervical disc, like pressing one of her nerves, and it causes pain in her shoulders and her arm. Same injection could work for this?
Very similar to the sciatica, actually. We call it radiculopathy as well, but we call it cervical radiculopathy, which is coming from a cervical disc. The etiology and the pathology is the same. The disc is herniated out, putting pressure on the nerve root, cause pain going down the shoulder and down the arm. You sometimes numbness and tingling, and in the more advanced cases, then you feel weakness too in the hand. And then while they're holding the things, they may drop. But the treatment usually starts with NSAIDs. If it's a chronic pain, usually epidural injection.
Worse.
It helps. How long it'll last, you really don't know.
Okay.
But the belief is that the epidural helps temporarily. So
Before I translate, how soon can I feel better right after the procedure?
Once you do the epidural injection, since there's steroid involved, it usually takes about 3 to 5 days.
Okay.
For the epidural injection to kick in and to start working.
Okay. I'll be back with more questions after translation. الحقيقة واحدة من الحاجات المهمة أو واحدة من الأوبشنز المهمة اللي نقدر نستخدمها في علاج حالات الآلام المزمنة هي فكرة الابيديورال انجكشن أو الحقن في منطقة اللي هي الفوق السحايا زي ما بنسميها. زي ما قال دكتور كوشار، دي معمولة لنوع معين من البيشنتس اللي هو فكرة انه الديسك بيبقى طالع لبره، الديسك اللي هو ما بين الفقرات بيبقى طالع لبره وضاغط على واحدة من الأعصاب. بتبقى صالحة لأي مكان، سواء الديسك ده موجود في الرقبة ضاغط على أعصاب الرقبة زي ما منال بعتلنا سؤالها، بتسأل ده ينفع كمان في الرقبة، ينفع في أي حتة في العمود الفقري طالما انه الديسك طالع ما بين الفقرات ضاغط على الأعصاب مسبب ألم وتنميل. ايا كان الديسك ده فين، مثلا لو الديسك ده طالع من الرقبه زي سؤال مدام منال بيبقى ضاغط على الاعصاب اللي موجوده في النخاع الشوكي وبيبقى عامل الم وتنميل في الايدين. اللي نفس الديسك لو طالع من الفقرات القطنيه وبيبقى عامل ضغط على الاعصاب بيبقى عامل الم في الرجلين، اللي هو مثلا واحد من اشهر الحاجات منه اللي هو بيبقى عرق النسا. ازاي البروسيجر دي بتحصل؟ يا ريت نحط معانا الفيديو رقم 1 بسرعه تاني على بالظبط كده على الشاشه. باختصار شديد انه في حاجه اسمها 3 طبقات من السحايا فوق، يا ريت نشغل الفيديو. دي بتبقى موجوده، بتبقى حاميه النخاع الشوكي. هو الازرق اللي طلع ده بيبقى مسكن موضعي، وبعدين بيدخل بابره بيحقن صبغه. فايده الصبغه دي انها بتاكد له ان انا في المكان الصح، الصبغه اللي حضراتكم شايفينها دي، وبيبتدي يحقن بعدها نوع من الاستيرويدز والمسكنات اللي بتسكن الالم في الاعصاب او في الديسك اللي طالع في المنطقه دي تماما. وزي ما انا قلت بتبقى صالحه لاي نوع من مشاكل الديسك اللي بيبقى بارز وضاغط على العصب في الرقبه، في البطن، في منطقه الصدر، في اي حته. طالما انه في ديسك ضاغط على العصب. سؤالي لدكتور كوشار كمان كان بتحصل بعد قد ايه؟ قال 3-4 مرات في السنه ماكسيمم نقدر نحقن البيشنت ونقدر نرجع نكررهم، بس مش اكتر من 3-4 مرات في السنه. سالته كمان بعد قد ايه البيشنت يقدر يحس التأثير بتاع الموضوع ده ويحس انه ابتدى يحس انه افضل والألم اقل. قال في خلال من 3-5 ايام بيقدر البيشنت يحس بالفرق على طول. One of the questions, when you would tell me, oh, it's not for you, it's like I'm one of your you're one of my contraindicated patients for this injection.
I didn't catch the question right. What are the contraindications for doing epidural injection?
Right.
Well, as I said, epidural injection is not for everybody.
Okay.
So if I see someone's pain is axial, like someone who has more of a back pain and the pain doesn't radiate to the legs or doesn't radiate to the arms, I know that the pain, the nerve root is not inflamed, is not irritated. So in that case, usually epidural injection is not the treatment of choice. And try to focus on other kind of treatments, such as, for example, facet joint block or medial branch block and radio frequency, so which I'm going to talk about them later. But epidural injection, as I said, is not for everybody. It's not for treatment of any back pain or any neck pain. There are, of course, contraindications for doing epidural injection. Someone who is on blood thinner, for example, like someone who takes Coumadin or Plavix, they had like a coronary stent placed and they have to be on blood thinners, they cannot go through epidural injection. Because if you do epidural injection, one of the side effects or risk of bleeding in the epidural space. And if someone is on blood thinner and it bleeds in the epidural space, that develops a hematoma in there because epidural is a contained space and can cause the patient to go paralyzed within 8 hours.
Wow.
So that's a devastating problem.
Okay.
There are other contraindications such as infection going on. If there's infection at the site of injection, then we cannot do it. If there's a pregnant patient, we cannot do the epidural injection for pain. There are different kind of like reasons for not doing the epidural injection, but indication is very important to put the right diagnosis and find the right candidate to go through epidural injection. That's why we hear someone says, oh, I had epidural injection 3 times, none of them worked. Well, probably you were not a good candidate to get epidural injection. Probably you should have received a different kind of injection or different kind of procedure.
Okay, since you mentioned different kind of procedure, right, let's talk about the facet medial branch block nerve. We'll have the video and you can explain to us like what happens, who would be a good candidate for those different kind of procedure.
So before you put the video on, let me actually go over the facetogenic pain of the back or the neck, and then we put the video on and then we go over the technique of doing the facet joint block or medial branch block.
Sure.
So facetogenic pain is a pain that is usually in the back and does not radiate to the legs, in the back and the buttock usually. The facet joint pain usually gets worse by sitting or standing for a long period of time. Usually the patient, when they get up first in the morning, they feel stiffness and pain in their back, and once they do a few steps and they stretch a little bit, the pain may subside, but towards the end of the day, the pain comes back again, usually by standing for a prolonged period of time. Facetogenic pain can be very painful, but is usually an aching pain. It's not a sharp shooting pain such as sciatica.
Okay. So it's more of a localized pain.
Is usually localized in the back.
Okay.
And usually the lower lumbar facet joints are the ones that are involved. But why do we get facet pain? Usually because the disc or the cushion between the two vertebrae are thin and the joints are closer to each other. They're kind of like, in layman term, they say we rub against each other. And that's why we get the facetogenic pain. However, it's usually in someone over age of 50 with back pain, it's hard to find an isolated etiology for the pain, which means that if they have facetogenic pain, they usually have disc problem too. Or if they have discogenic pain, they usually have facet joint pain too.
Okay.
How we treat the facet joint pain?
Right.
One treatment is to go and inject inside the facet joint, steroid injection, usually the same way that you do at the knee or any other joint, you go inject steroid and come out.
فيديو رقم 2.
But what you are going to see in the video is another treatment which we go in and first we test it. So we want to put a diagnosis first.
Okay.
We want to make sure that the pain or the majority of the pain is coming from the facet joint. We go in with a needle at the little tiny branch of the nerve which is called medial branch nerve, and that's a sensory nerve that transmits the pain from the facet joints to the spinal cord to the brain. That's how you feel the pain. So we are going to block that little tiny branch of the nerve, and the patient goes home. If the pain is subsided and the patient is
So-
better more than 80%,
That's the source of the
then
pain.
we know that's the source of the pain.
Okay.
Well, what do we do next? We have the diagnosis, we know where the pain is coming from. How do we treat it, like in long term? The other treatment that follows the medial branch block is radio frequency ablation or neuroablation. Neuroablation means killing a nerve. We go in and we heat up the nerve by giving it radio frequency waves. So by radio frequency waves, we heat up the nerve, we burn that little tiny nerve that transmits the pain.
Okay.
So therefore, the patient is not going to feel the pain of the facet joints.
Okay. الحقيقه النوع الثاني من الحقن يعني بيبقى للعصب اللي طالع ما بين المفصل او بنسميه المفصل السطحي او الفاسيت جوينت زي ما دكتور كوشار قال. ودي بتبقى اكتر في الانواع الالم اللي بتبقى متركزه في الظهر بس ما بتنزلش للرجلين زي مثلا عرق النساء. عرق النساء بيبقى احسن له النوع الاولاني من الانجكشن اللي شرحناه لحضراتكم. ده نوع من الانجكشن هم برضو باختصار بيدخلوا في الفقرات اللي ما بين سوري انا اسف في المفصل اللي ما بين الفقرات ويحقن ماده مسكنه. الماده المسكنه دي بتقول له اذا النيرف ده او العصب ده هو مصدر التعب ولا لا، وبعدين يبعتوا البيشنت للبيت. اذا فعلا مصدر الالم ده قل، معنى كده انه النيرف ده هو مصدر التعب ده. لما بيرجع تاني بيستخدموا نوع من الموجات الكهرومغناطيسيه بنسميها راديو فريكونسي ابليشن عشان يدمروا الروت ده خالص او يدمروا الجذور بتاعه النيرف ده اللي عامل كل المشكله وكل الالم ده في الباك. وبتبقى بروسيجر تانية بعدها ب5 ل7 ايام. I have a question here, like those kind of injection, how long do they last, the effect?
That's a tough question to answer.
Okay,
So
everybody's different.
the answer to that question is that it's very, very unique to each individual.
Okay.
It depends on the severity of the problem. It depends on what the etiology is. It depends on whether there are any other factors causing the pain. But on average, I expect an epidural injection maybe a few months. I've had patients that had epidural injection, usually younger people. They say, oh, the pain went away for a few years. And after a few years, it's coming back.
Okay. الحقيقه مدام مها بالنسبه لسؤال حضرتك اللي بتسال الحقن ده بيضيع مفعوله بعد قد ايه، زي ما قال دكتور كوشار كل واحد مختلف عن التاني. احيانا الحقن ده بيقعد بثلاث 4 شهور، في ناس بتقعد شهرين، بس زي ما انا قلت قبل كده بيتكرر 4 مرات في السنه بحد اقصى. فده بيجاوب كمان على سؤالك التاني اللي هو بيتكرر نفس الحقن ولا لا. بيتكرر تاني. انا بتكلم عن النوع الاولاني من الانجكشن. النوع التاني بنموت فيه الجذور نفسها بتاع العصب ده، فما بيرجعش نفس العصب يعمل ألم إلا إذا حصل ألم في منطقة تانية. كده أرجو أكون جاوبت سؤالك يا مها. بالنسبة للنوع التاني من الانجكشن زي ما شرحناه ووريناه على الفيديو، ده بيستخدم في الآلام اللي متركزة في منطقة الظهر اللي ما بتنزلش لمنطقة الرجل بشكل عام. Any contraindication for the second kind of injection, which is facet block joint?
Usually not. I mean, for the facet joint block or medial branch block, I mean, besides that's the general contraindication of getting injections, such as someone who has a bleeding tendency or someone who has an infection going on, there are usually not any specific contraindication for doing the medial branch block or the radio frequency ablation. I mean, for radio frequency ablation, someone who has a pacemaker, we cannot use the radio frequency. Someone who has a spinal cord stimulator in, we cannot use the radio frequency because that can kind of damage the pulse generator of the of the pacemaker. But besides that, besides the general contraindication of doing injections, there is nothing really specific.
اوكي. الحقيقه برضو من الاسئله اللي جت الحقن ده، يعني ايه الحاجات اللي ما ينفعش نقدر نعملها مع الحقن ده؟ واحده من الحاجات المهمه جدا اللي قال عليها دكتور كوشر انه الناس اللي بتاخد مسيلات للدم وهو تحديدا قال الكوميدين، الوارفرين، البلافيكس، كل دول الناس اللي بتاخد مسيلات للدم ما نقدرش نعمل معاهم الانجكشنز دي، لانه لو ابتدوا ينزفوا وده ضغط على العمود الفقري هيعمل لهم شلل بشكل يعني بسيط جدا. بنشرحها لحضراتكم، ولكن الناس اللي على مسيلات الدم ما بنحبش نحطها على النوع ده من الانجكشنز. النوع الثاني من الانجكشنز اللي بيتبعوا نوع من الموجات الكهرومغناطيسيه، الناس اللي بتبقى عندها منظم لضربات القلب البيس ميكر ما بنحبش نحطها عليه، لانه او سباينال كورد ستيميليتر، وده هنناقشه الحلقه الجايه. برضو ما بنحبش نستخدم الانواع دي من الموجات الكهرومغناطيسيه عليه. At the end, I'd love to thank both of you. It was very informative. Thank you so much for being in White Coat and being part of White Coat family. And we'll have part 2 for to talk more about the radio frequency ablation, spinal cord stimulator, and the spacers. So thank you so much for being on White Coat today.
It's a pleasure to be here. And the field of pain management is a very advanced field, and there are a lot to talk about. Hopefully we'll cover some more topics in the next session.
And please, if you have any questions, just reach out to Dr. Khoshsar at BioHealth Pain Management website. We'll have this website on our Facebook page today, so feel free to contact them. Thank you so much, Dr. Hisu. It was very informative.
Thank you very much.
بشكر حضراتكم على التفاعل وعلى حسن المتابعة، ونشوفكم إن شاء الله حلقة جديدة من وايت كوت الأسبوع الجاي.